Good morning, everybody. Welcome to Pediatric Grand Rounds. Today we have the group effort from Care Connection for Children. We have a special welcome to Dr. Kimberly Dunsmore, our brand new Chair of Pediatrics. Today we have Dr. Violet Borowicz, who is a pediatric hematology oncologist and palliative care specialist. She's the medical director for Care Connection, and with her, she has Ms. Fellabaum, Ms. Campbell, and Ms. Sforza, and they will introduce themselves a little bit more. Thank you.
All right, so we thought that we would talk about Care Connection just a little bit more, since a lot of people don't really know what Care Connection is and what Care Connection does, so we wanted to give more information. I became the medical director in June of this year. Dr. Miller, in one of her many hats, used to be the director prior to her retirement. And then Dr. Moore had taken over for a few months before he also left. So I assumed the role in June of this year. We have no financial disclosures. So Care Connection for Children is actually a part of the Virginia Department of Health. It is sponsored by the Virginia Department of Health. It is a statewide network that of regional programs that provides health care coordination, community support, and resources to children who have special health care needs. So I'm going to have all our members of our team actually introduce themselves so that you guys know who the entire team is. I already. Okay.
Hi, I'm Tammy Campbell. I'm the program director. I'm Patricia Sullivan. I'm the educational consultant.
I'm Sforza, RN care coordinator.
And I'm Jolene, also an RN care coordinator.
And I'm Doreen Morton, RN care coordinator.
And I'm Chris Houghton. I'm the BSW care coordinator with Care Connection.
I'm Kate Fisher. I'm the administrative assistant. And I'm Brenda Taylor, parent resource coordinator.
So Care Connection for Children, the eligibility requirements, they actually have to be a resident of the Commonwealth of Virginia. And they have to be under the age of 21. We cover birth to 21, and diagnosed with a physical disorder that's expected to last at least 12 months. To be eligible, they have to have proof of residency in Virginia, and a post office box is not established residency in Virginia. And then, so their examples of verification could be motor vehicle registration, a Virginia driver's license, proof of payment of Virginia state income taxes, proof of enrollment in a local school, a lease, utility bill that's in the name of the child's parents or legal guardian. The pool of funds that's given to Care Connection is actually based on their location within Virginia. Documented and undocumented persons are eligible for Care Connection if they are Virginia residents. Those who are on temporary visas are not eligible unless they have written documentation from the U.S. Citizenship and Immigration Office that they have applied for permanent residency. And then verification of immigration status may be requested during the process. So requirements for admission for ongoing case management. Again, like I said, resident of the Commonwealth of Virginia under the age of 21, and then diagnosed with physical disorder. We expect it to produce one or more of the following sequelae. So they have to have need for health care and ancillary services over and above the usual for the child's age, or they're requiring special ongoing treatments, interventions, or accommodations at home or school. They have limitations in function, activities, or social role in comparison to the healthy aged peers in the general areas of physical, cognitive, and growth and development. And then there is a dependency on one of the following to compensate or minimize limitation of function, activities, or social role. So medication, special diet, medical technology, assistive devices, or personal assistance. So part of the Roanoke area, we actually cover 33 counties, and we are in the light blue here is where we cover. I did not list all the counties out since there are 33, but if you guys have any questions about which counties, the team can always answer those. So as medical director, I kind of serve as a liaison for the medical diagnoses and the medical part of Care Connection. The people who have the following primary diagnoses do not actually meet the criteria for the case management or pool of funds. So if they have abnormal vision due to refractive error, allergy, asthma, cancer, tumors, hemophilia and other bleeding disorders, HIV, AIDS, mental health disorders, and then developmental disabilities. If these are the primary diagnoses, they don't qualify. If they have another diagnosis with this and the other diagnosis is their primary, they actually will qualify for Care Connection. And then if we have kids who do not qualify that were referred to us, we will try to work to make sure we still get them community resources that are not under case management. So again, like I said, my role is really to act as a liaison for clinical and medical questions. And then we also have a big push to try to help with the transition to adult care. A lot of these kids, as they age out of our system, are having a lot of difficulties with the transition to adult care. So I had sent out an email a couple months ago, and only 2 people replied to me with adult specialists that they refer their kids to. It would be really beneficial if the subspecialist actually sent me the list of adult providers so we can actually help our kids with their transition to adult care. And Tammy's going to talk about the referral process to Care Connection.
Hi, good morning. I'm Tammy Campbell. I'm the Program Director for Care Connection. I have been with the program since 2016, and I'm also the Pediatric Reimbursement Manager. I wanted to talk a little bit about the referral process. It's a little bit different than the referral process within Carilion. Referral is sent to Care Connection. It can be verbal. We do take Epic in basket, but usually it's by phone calls. Referrals should include diagnosis, the name of the client, date of birth, parent name, address, and phone number. This information is needed to make sure that they fall in our catchment area. The family has to consent to wanting services by Care Connection and really need to give a verbal consent before being referred to our program. The information of referral is handed off to the program director for assignment. Once the program director reviews the caseloads for the care coordinators, then she determines which care coordinator will take that assignment. This referral is given to the care coordinator with a timeline of contact within 2 to 3 days. 3 attempts are made by phone. If unable to contact, a letter is sent to the parent requesting a callback, and then it's documented in our Sun system, which is similar to the Epic system that you all use. If after 2 weeks there's no reply, a pending referral is then closed and the referring agency or provider is notified. After contact with the client, a consent form is either mailed or given in person if able to do so. We are unable to provide services under our CCC grant without a signed consent because this is a voluntary program. The parent has the choice of wanting services or not, and they can choose which center they would like to be assigned to. We do have 6 service areas that are within Virginia. When consents are completed and returned to our office, the administrative assistant enters the documentation in the Sun system. Once the client is assigned a number, the completed enrollment package is given to a care coordinator. And at this time, I'd like to turn the program over to Jody Sforza.
Thank you. Good morning. Again, I'm Jody Sforza, RN Care Coordinator. And last week when Dr. Henschel was here speaking, Patty and I, we kept looking at each other through the whole speech saying, we do that. And it's just, you know, one of the reasons we're here is because a lot of people don't know about Care Connection. And it's a great program, and we hope after today that you'll think of us when you see us. Right. What we help do is we find pediatricians, specialists, and other healthcare providers to learn in the local area, or we cover a huge area. So when we're in Roanoke, it's pretty easy to do, but when we're in the patients are in outside areas, it's kind of difficult. We cover such a large area, but we help find community resources, and that includes anything you can think of, transportation for patients, medical equipment, anything that, and support groups that we can connect families with so they can know each other. We also have our educational consultant, and if the family is having problems at school with their child, then Patty will become involved with the care coordinator, and we set up a meeting at school for an IEP or a 504 meeting, and go to the school and try to find out what's going on to help the family and the child. Okay. We also, funding for Care Connection is done through the Title V Maternal and Child Health Block Grant. And all this came about as a result of the polio epidemic that occurred in 1940s and 50s. And at the peak of the polio epidemic, there were more than 500,000 people that were affected worldwide. So Care Connection over the years has had many different titles. The program began as the Society for Crippled Children of Southwest Virginia. Then it became the Bureau of Crippled Children, and then Children Specialty Services, and now we are Roanoke Area Connection for Children. In 1950 to 1965, poor children had very limited access to health care. In 1965, President Lyndon Johnson expanded Medicaid to cover children with special health care needs. The expansion of Medicaid gave children with special needs a comprehensive health care plan. It included mental health services, testing, screening, immunizations, medications, therapies, medical equipment, hospitalizations, and access to specialty clinics to prevent care as well as for sick visits. Virginia recognized the need for providing these comprehensive services to children, so a clinics model was created. Okay, Care Connection was known as the Society for Crippled of Southwest Virginia, and orthopedics was the original clinic started by Dr. Philip Trout, Dr. Lewis Ripley, and Dr. Charles Bray from the Roanoke Orthopedic Clinic. And then in 1975, this office underwent complete, went under complete state supervision. The state actually reimbursed all the salaries, but there weren't any benefits for employees at that time. The Care Connection office, which was known as Bureau for Crippled Children, was comprised of Roanoke Memorial Hospital employees and state employees. Clinics that were provided were neurosurgery, urology, hearing impairment, eye surgery, and eventually cardiology and neurology. In 1974, the office underwent went under state supervision. In the mid-90s, medical expansion allowed for pediatric specialists, Medicaid expansion allowed for pediatric specialties to open their private practices to Medicaid recipients. At that point, access to care was addressed, but many patients still didn't come to scheduled appointments for lack of transportation or the inability to understand the treatment plans, and that's how care coordination started. Okay, in 2003, the program changed from the clinic model to the care coordination model. The name changed to Roanoke Area Care Connection for Children, which we are right now, serving children with special health care needs through care coordination services versus the direct clinical services. In 2010, Care Connection for Children moved from the Roanoke City Health Department to Carilion. Let's see. Okay, what we use is the team approach, and that pulls together the care coordinators, the medical personnel, educators, and family members to determine how we can help the children with special care needs to reach their maximum potential. Let's see. We have, like I said, we have many different people within our organization. 3 of our RNs started out in the NICU, and so they fully understand the problems that families face with children that start out there. And we have our social worker who is very well versed in insurance options and discharge planning and things like that. Let's see. And Patty does the education, like I said. And we also try to connect families with each other. If we see families that are dealing with the same problems, we get permission from them and have them talk to each other. We also recommend support groups. There are several online support groups that we give them the information for. Okay. With that, we'll have Patty talk.
Good morning. I'm Patricia Sullivan. I'm the sorry. I am the educational consultant with Care Connection for Children. As part of the collaborative effort with the Virginia Health Department and Carilion, I am actually a Virginia State Department of Education employee. So I'm a little different from everybody else. My background is special education. I've done lots and lots of different things for 35 years. I know, how can that be? I'm only 42. I don't get it. But as Jody was saying, in my role, what I do is I work with the care coordinators and the parents in understanding the medical diagnosis that their child may have just received and what those educational services could look like for that child in the school system. So that might mean just explaining the difference between a 504 plan and an IEP, understanding what the law covers, what it doesn't. We can go to IEP meetings or just school-based meetings. I like to use that word because that's not as threatening as an IEP meeting. But a school-based meeting to just talk about what does this child need every day at school in order for him to be successful. The schools have been very receptive to us coming in and talking to them. Am I?
No, you're making me nervous that you're going to pull this off.
Oh, I'm sorry. I'm sorry. Clearly, this is not my forte. So I walk over here. No, I lost my train of thought. The schools have been great, and like Dr. Borowicz is saying we serve many, many counties, from Allegheny to Pittsylvania County, and so when we do have meetings here in Roanoke, we're very happy about that. It's not so far to drive. Other things that we can do, we have attended or we've recommended summer camps for kids. We've visited summer camps with families. We have visited adult programming. You know, when children move from high school, you know, what are they going to do as an adult? That's a transition, so we work together on the medical transition along with their life. You know, what are they going to do when they move into the real world? So we have done adult programs, Woodrow Wilson Workforce and Rehabilitation Center. Let's see, what else? We do lots of follow-up. And the good thing about serving our children 0 through 21 is that we are able to build long-term relationships. And we had a little girl, or a young lady, I should say, who graduated this year, and we knew her from when she was very small, and we worked with her, the family and the school, in making sure that her educational program was appropriate for what she needed and then where she's going to go as an adult. So that's just some of the things that an educational consultant can help the care coordinators with. Yes?
Alex, do we need to use the mic?
Don't ask me anything hard.
All right, about the square root of it. No.
Yeah, no.
No, one of the things that it's very helpful to hear this. Perhaps we could all kind of more in depth, because I'm sure you overlap. I was looking, I kind of came in early and saw what it does not cover. And it looked like developmental disabilities, autism, a lot of the patients that I deal with who have comorbid features, G-tubes, orthopedic issues, cardiac issues, trach, vent. That's where I'm a little confused as to, because I'm sure there's a lot of understanding, because you talk about the IEP and so forth, but I believe I heard you exclude developmental disabilities and primary.
If it's a primary diagnosis, then the developmental delay is small, but the trach kids, we like, there is a
G-tube kids? Cardiac
yes,
kids?
if they have a primary diagnosis, I'm just going to make this up, a seizure disorder, but they also have autism or intellectual disability or anything like that, we can pick those kids up because their primary diagnosis is not autism or intellectual disability.
Okay. So,
it is a secondary.
Well, but many times they end up, the best example I deal with a lot is feeding kids. You know, I got the weekly feeding clinic, and it's oftentimes perinatal asphyxia or some sort of congenital, you know, I'm sorry? Brain tumors. I was going to take that whole list here. I got psych, I got genetics, I got Downs, I got trach, I got feeding tubes, cardiac, orthodevelopmental. I mean, because if you can help us, I mean, I send all my patients, but I mean, so they all know the route to your office. But I think that that's where it's kind of confusing to me. I guess I'm assuming that there are ways to kind of work around the legalities of, oh, they have autism as a primary diagnosis, but I had to put a G-tube in them because they were malnourished. Would that be okay? Would they be covered? I mean,
I'm not sure, because it has to be a medical diagnosis.
Well, I mean, we know how the game's played. We can come up with the medical diagnoses. I'm being facetious, but I'm not trying to be cynical. I'm trying to be serious.
Right.
We can come up. It helps us to know what you need us to say. You know, if it's a primary brain tumor, or it's a primary orthopedic, I think cerebral palsy is a good example. I assume that's kind of what this was geared for. And they need a G-tube, and they got feeding problems, and then we're good. But
we're good.
As you all know, I see a ton of autistic kids.
Right.
And they have a lot of problems, and they all need IEPs, and they all need, but I may need help knowing what primary to put down other than, does feeding difficulties count?
As long as it has a valid ICD-10 code, yeah, as long as it's identifiable.
I'm sorry, I wasn't very helpful with that.
No, that's all right.
It does get
great service. I just send all my patients there, and they're getting taken care of.
So many of our kids have multiple diagnoses. So as long as whatever those that are excluded is not the primary, then we can take them. And I have lots and lots of kids.
Can you shuffle those yourselves? I send you a shopping list of diagnoses.
Can we do that? How does that work? I think that is the referral process.
Can we resend the referral if it doesn't qualify? Yeah, Dr. Okay.
So recently we met with Marcus Allen, who's in charge of this program through the state, correct? And it sounded to me like they were a little bit more strict with what the primary diagnosis was and the exclusions that they put up on the slide because it's state funding money. So I don't know that we can be as liberal with our diagnoses as what we would hope to be able to do.
And the thinking behind that is that there are lots of programs and services for children who have autism, who have intellectual delay. You know, so I think what you just said, the program is kind of looking at children who have lots and lots and lots of issues.
I think also it's because of the funding mechanism, so that there are limited funds, and I don't know what your caseload is per county, but it really is based on your geographic location, how much funding you get. So if we overwhelm the system with every child who needs some sort of care, then the program is hampered in many ways by being able to be efficient and effective. And so I think that's why the state has come up with these diagnoses of exclusion in an attempt to try to cover as many children who are lacking in other resources, even though we know that our children need these resources.
Well, I mean, a good example might be sickle cell. You know, if somebody comes to you and you say, well, we've got that covered, can you triage them to the appropriate state resource offering, if you will?
So previously, sickle cell actually wasn't covered under care coordination either, but because we are not receiving special funds from the state for sickle cell kids, we are actually going to include our sickle cell kids in this area under Care Connection. And that was part of the meeting that we had with Marcus Allen, was to include our sickle cell kids in this area. But there's actually a state-funded program separate for sickle cell patients.
I mean, if there are separate state-funded programs, can you get the right endpoint? That's what I was trying to.
Usually we can provide those resources to where they should go.
You guys are making me work for it.
You can always make the referral, and you don't have to figure out whether they would or wouldn't. Make the referral, and then we can go take it from there. Yeah, there you go. And then this way, if we can't, we could make the referral to somewhere else.
Now you're back on track.
I'm actually finished. I'm just standing here. So, are there any other questions about education?
Well, I'm sorry to keep. What about the situation where there's a huge psychosocial family dynamic problem? Can you? Because I send those patients to you as well. I don't know quite. I mean, we see a lot of, face it, those with chronic illness in pediatrics who deal with chronic health problems. We all know full well that the Medicaid rate is huge, the divorce rate is huge, family dynamic rate, child abuse, you name it, et cetera, et cetera. Do you have the ability to facilitate getting those patients to the proper, in terms of family dynamics? They need counseling, they have potential abuse, financial straits, getting transportation.
We do a lot of that, and like you said, our children have so many needs. But my role in school, if I had a child like that, I would work with the school and the school counselor to try to see that child, to get that child some services through family preservation or therapeutic day treatment, whatever they need in the school. And many times those services will overlap to the home. So, yes, to answer your question, yes.
I just wanted to add that Patty and I actually got invited by a family to go with them for counseling with Dr. Dudley. So that's the type of relationships we can work with the families if they let us.
And that was very interesting because I was, well,
I'm just the educator. Do you really want me in that session?
they did, so.
I think is that the conclusion of your presentation? Okay. Are there any questions in the room? I think I've seen a couple online, but I think we've covered a lot of it.
So before the phone call from me is made to you for the referral, do I need a specific consent form from the parents to have you be able to call them? And then my follow-up question is, someone said in 2 weeks you'll send a response back to us with appropriate information that you were able to get in contact or where you sent them. What all does that response entail?
Hot potato?
Well, so the referral is made to us. You do not have to have a consent form for the referral to be made for us, but they need to sign the consent form for us to be able to provide them services. So they're not officially enrolled under Care Connection until they fill out the paperwork, which is a one-page form that Kay has kindly highlighted everything that they actually need to fill out. If in 2 weeks they have not gotten back with the form, usually it'll involve a call to the referring provider's office just to say, hey, we have not been able to get in touch with the family, and we haven't been able to follow through with this referral. So at that point, you can either follow up with the family yourself and just say, do you still want to do this, or are you not interested? And even find out, because we cannot find out from the family what their limitations are in being able to fill out the form. So if you took that step to say, is there anything I can help you do to fill out this form to get you involved if this is something you want to do.
I have a question about our refugee population, and this may be ignorant, but do they usually qualify in terms of Virginia residency?
Yes.
Okay.
Yes, the undocumented residents will qualify.
Under a special visa from the Department of State or whomever it is that helps coordinate refugee services. So they won't be deported for that. Somehow. Yeah.
So one of the other things I wanted to explain about the referral process when you ask about what you needed to do, it has to be a voluntary basis from the parent because the parent doesn't have to agree to our services. It's not like a regular referral in Carillion when you send a referral to a specialist or another office and it goes into a work queue, the referral coordinator works that referral and makes the authorization, makes the appointment, contacts the patient, and sends out patient information. With us, we have to make sure that parent agrees. So even though you think they may need the services, if they decide, well, right now I really don't want that in the program, then we can't do anything with it but close it out and let you know that that's what we've done. At 1615 Franklin Road.
Let's put that into a building first.
We're in the basement of the home health building.
Just to make it simple, if you do have a family you want to refer, just ask them, would you be okay with us referring you to Care Connection? And if they say yes, then you just call us or send us a note or whatever, just to make it easy, and then we'll take it from there.
So I wanted to thank you for such an informative session so that we know what is available for the children of our community. You have a very large geographic area that you have to cover, and because state funds are really based on tax base for what is in your area, I'm wondering what your caseload is like, because that really determines how many services that you can provide for each individual child and family.
Are they all doctor reported for 75?
Yeah, that's all my patients, right?
75 per care coordinator. Okay. And you can stay in that level? Well, it comes and goes.
It fluctuates. Some families, if we continue to try to contact them and they don't respond, we take different steps and we'll send a letter. If they don't respond to that, then we'll close them to make more room. 75 per care coordinator, 75 children.
Okay, so as part of their grant, we have to do a request for proposal every 5 years. So with that, we have 375 cases for our whole center. Each full-time care coordinator has 75, and then the part-time has 50.
Family that you may yourself,
by Dr. Hunt.
Practically speaking, tell me about
As far as like child protective services,
yeah.
Yes, we have done that. If it's necessary, we do.
As the educational consultant, I don't have a cap on my caseload. And right now, I cover about 60% of all of the children. And so it's a lot. It is a lot. But, again, those kids, it ebbs and flows. Some kids, you know, need you once a year for something. Other kids might not need you for a while. And then some are just on fire all the time. So it just kind of depends.
We've spent a fair amount of time talking about exclusions. Can you just give me an idea of maybe your top 5 diagnoses or what your patients look like? I did notice that endocrine was not an exclusion, so I'm assuming diabetes would be one of your.
Diabetes is a big one that we have, yes. There isn't a specific list of diagnoses that we cover. The state only provides the exclusion list.
But you could get a top 5 diagnoses. You know, these. I'm just trying to envision what your patients look like. That's what I'm trying to get at.
Cerebral palsy.
Cerebral palsy.
Better help me. We know a lot.
We're just very nervous. I'm sorry. Yeah. Okay, girl, cut me. All right. Diabetes, heart disease, seizure disorder, cerebral palsy, genetics. I'm sorry. Hearing impairment, cleft lip and palate.
So you said genetics,
yes.
All syndromes and...
Yes, all syndromes.
That's another one. He's got 70 more patients.
So the other thing is the care coordinators actually do go to the IDT meetings on inpatient, so NICU IDT, PEDS IDT. They're actually a part of those meetings. So if there are kids in the hospital, the care coordinators are available for those kids if they haven't been referred to Care Connection already. It's a huge thing, especially in the NICU when these kids are preparing for discharge. The care coordinators are there to sort of help with that transition. They get enrolled on Care Connection at discharge usually from the NICU.
Right.
They're also going to cleft lip and palate clinic, and they're not
and hearing impairment
clinic. Yeah. So they are really involved with Dr. Jaya Kumar as well.
Yeah. We're trying to figure out how to do the IDT meetings better because they go so fast, and the caretakers that are there know the patients real well, and they're going boom, 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 and we're like, what, when, you know, how? Maybe they would fit for us. So we're just trying to make ourselves more visible, and that's why we're doing this also, so to make people more aware that we're here.
I'm trying to understand how your services differ from, let's say, the child development clinic, because there seems to be a great deal of overlap. So who would refer to you versus if they're already in a service like that?
Okay, so if a child goes to the child development clinic, they're basically being assessed and diagnosed, and then it's a clinic model. Okay, so what is different about that is that we take the whole child, it doesn't matter what the diagnosis is, and I can attend, for me specifically, I can attend IEP meetings, I can do things with the family. The child development clinic, they cannot do that. They don't, it's just a different model. And they don't carry their children as long as we do. So I can
How long do you carry them?
21 or 22.
And then to follow up on that question, Care Connection versus, say, our local community service boards, say the mental health resource centers, the medical home pluses, things like this. Should we still always refer to the community service board as like just a go-to? Care Connections is a good secondary? So I think everyone should have a community service board representative for some governmental help.
I think it really depends on what services you're looking for, because there may be services that they have that we do not. So we have a number of resources that we send our clients to. So you can still refer them to us, and if it's something that we can't handle, we can actually send them somewhere else.
Any other questions in the room? Oh, okay.
Comment.
You can do comment.
My name's Keith. I'm one of the chaplains here, and actually I'm a parent of a child that we worked with, Care Connections, and what they helped us the most with was navigating through the process as a parent coming in, not knowing anything about any of the resources that were in the area. They were helpful, easy to work with, and very helpful at plugging us in. So from that aspect as a parent, very helpful.
I'm thinking specifically of our brain tumor population, and they have a lot of needs, school needs in particular, and we don't know of resources in the community to help those children. Would you guys be willing to help us with community resources since they don't, you know, they don't qualify for your program?
The brain injury.
Yeah, they would say qualify.
You're talking about the birth
diagnosis is a brain tumor.
You're talking about birth injury, aren't you? Brain injury. No, there's a brain injury.
Like for traumatic brain injury?
Oh. Yeah, there's the brain injury services. I forget the title of it, but it's down Franklin Road, and it's mostly traumatic brain injury. But I mean,
they have very similar needs.
Very similar.
Even in terms of driving, you know, those children have a lot of, and we don't have a lot of patients with brain tumors, so I think they end up feeling very isolated within our community.
Anybody want to comment?
There's a lot of, if the patients are on Medicaid, there's a lot of services available to them, like transportation, to the doctor appointments, to therapies. A lot of people don't even know that. You would think if they have Medicaid, they would know the services, but most people do not.
About Medicaid caps.
Okay. Specific to brain tumor.
Yeah, or children with other diagnoses that don't qualify to have needs.
Might be a good topic for an additional discussion afterward, like what are resources for kids that fall outside of what you all do. That might be an entire session in and of itself.
You mentioned one thing briefly, and that was the life transition, which is very important. I can think of individual Downs, 18 years old, who went up to Tammy, I believe. You mentioned Woodrow Wilson. You guys can help life skills, referrals, and so forth, facilitate that?
Yes. For a child like that, part of their educational transition is that piece right there. And so we would work with that educational team, and when I say we, it would be whoever's the care coordinator, we would work with that school and that family. The Department of Vocational Rehabilitation comes in, and we talk about those things, and sometimes we will visit those programs with families. I mean, we've done that to make sure that they have a full understanding of what those services look like. Many parents are very apprehensive to send their children, you know, to residential, because that's basically residential for a short period of time. But once they get there, the girl we went with, she said, "Oh my gosh, it's just like a college campus," and it's lovely. And so families are very excited, and so yes, we do assist families with that. And if the child is not appropriate for something like that, we have also explored day programs for children who have more involved needs, long-term residential. And so another thing, just to kind of what we do, we support the families. We are a supportive, whatever they need at whatever time in their lives or their children's lives, we support them in accessing services.
Okay. I'm going to go ahead and unmute the phones here. We have quite a few people online, and I've already received a few questions submitted, but I think we've answered most of it was, do you have an inclusion list? But it sounds like I think we've discussed that enough. So if you are on the line and you do not want to make a comment or have a question, if you would just please mute your phone.
The conference is now in talk mode.
Okay, if you're on the line, we can hear you. We can also hear what's going on in your background. So please, if you do not want to make a comment, put your phone on mute. I don't know if I've said that enough. Anyone on the line have a question or a comment for our presenters?
You got my favorite top on. Hey, it's Emily Doherty.
Yes, Dr. Doherty, go ahead.
I have a question for, probably for Kay. So when we're describing Care Connection to families and offering to do a referral, like I feel like sometimes saying community resources is too many syllables for some of the parents that we take care of. What kind of freezing?
Hang on a second. If you're on the line, can you please mute your phone if you're not Dr. Doherty so that we can finish your question?
Okay. So what's like a 1 or 2 sentence description that we can tell families to kind of sell the referral?
Just selling them on a referral to Care Connection.
So,
97. There it is. There is no charge, no cost to be enrolled in this program.
All right.
Well done.
One of the things that I try to tell families is you're here to help a family navigate some of the systems and to know what the resources are that are available for these children.
Does that answer your question, Dr. Doherty?
Yes, and I want to thank everybody with Care Connection for helping me with many of my genetics patients over the last 10 years. Thank you very much.
All right. Anyone else on the line have a question or want to make a comment? No? Anyone else in the room have a question or want to make a comment? All right. Thank you all very much. If you are still on the line and you want to ask a question, you can always email us at outreach@careorg and I can get them to the presenter. With that, we're going to disconnect the phone lines now. Thank you all very much for joining us.